Hello everyone, my name's Hannah. I'm one of the CTFs at SWBH. Today we're going to be talking about acute coronary syndrome. So we'll be going through the definitions and prevalence, the pathophysiology, some risk factors, typical presentations, differential diagnoses, some investigations, immediate management, and prognosis and complications. So acute coronary syndrome describes necrosis of myocardial tissue due to ischemia. It's usually precipitated by a thrombus. Coronary heart disease remains a leading cause of death in the UK, with 1 in 5 men and 1 in 7 women dying of CVD. 38% of those with an episode of ACS pass away within 1 year. So ACS is a spectrum of clinical syndromes of the same disease process, and they consist of unstable angina, non-ST elevation MI, and ST elevation MI. So it's important to think of stable angina and MI as a spectrum of the same pathology. Angina describes intermittent cardiac ischemia due to narrowing of the coronary arteries, and therefore the pain arises due to increased oxygen demand which cannot be met due to the narrowing. Typically, therefore, it occurs on exertion, so typically physical exercise, but also emotional stress and strain, and it's relieved by rest and by GTN spray. The symptoms associated with ACS, so unstable angina and MI, occur at rest, and that's the way that we differentiate between the two. So another important point about stable angina are the symptoms. So typically patients experience pain or discomfort from that intermittent ischemia, and described as a tightness across the chest, radiating sometimes to the throat, arms, back and down to the epigastrium. As we mentioned, it's provoked by exercise and settles when that exercise stops, and it's not an acute coronary syndrome. So the pathophysiology of ACS, over many years, starting in adolescence, we get a buildup of cholesterol and fibrous tissue within the coronary arteries, and these form atherosclerotic plaques. The plaques can become unstable and rupture, and at this point platelets and other thrombotic factors form a clot around that plaque. This leads to narrowing and subsequent occlusion of the coronary artery. The myocardium supplies by that coronary artery become ischemic and subsequently necrotic. So this is just a picture representation of what we've just described. So on the left hand side we can see a normal healthy blood vessel. On the top we can see some fatty streaks have started to appear, and as we mentioned, these will start in early adolescence. On the right we see an established plaque, and you can appreciate that this might impede blood flow to the rest of the myocardium, and this is when a patient would get symptoms of a stable angina or claudication. And then the final picture at the bottom, the plaque has ruptured and we can see a clot's formed, and this would result in ACS, so unstable angina, an MI. If this was somewhere else, this could be an ischemic stroke or limb ischemia. So the process is the same. So it's really important to think about some differential diagnoses for chest pain. So on the cardiac side, we've got ischemic causes, so stable angina, and then our ACS, so unstable angina, NSTEMI and STEMI. Non-ischemic cardiac causes such as pericarditis and myocarditis, and then non-cardiac, so gastroesophageal, such as reflux, spasm and peptic ulcer disease, and then non-gastric causes such as aortic dissection, PE, pneumonia, pneumothorax and musculoskeletal pain. Again, that would be a diagnosis of exclusion. Okay, so next we're going to talk about some risk factors for ACS. So we've got modifiable risk factors such as smoking, type 2 diabetes, hypertension, hyperlipidemia and a sedentary lifestyle. And we've got non-modifiable, so increasing age, male sex, family history of heart disease, and people of a Southeast Asian background are at a 40 to 60% increased risk when compared to Caucasian population. A typical presentation of ACS would be a central crushing chest pain. Some common phrases used by patients are squeezing, burning or tight pain. Often there's some radiation to the left arm or the neck, and the patient might be nauseous, clammy or short of breath. 25% of patients, however, will have an atypical presentation, particularly women, older men and ethnic minorities, and some of their symptoms can include abdominal pain and jaw pain. On clinical examination, the patient may appear completely normal. You may not find any signs at all. However, they may have a mild fever, some pallor or some clamminess. They may be hypo or hypertensive, and if papillary muscles are affected, you might hear a new murmur due to some valve dysfunction. There may be some signs of heart failure, such as pedal edema or pulmonary edema, depending on the extent of the myocardial damage. So investigations, I like to categorise them into bedside tests, laboratory investigations and imaging. So at the bedside, it's important for any chest pain that we get some serial ECGs. Often that first ECG is normal or might have some minor changes, so we need regular ECGs to see for any dynamic changes. Laboratory investigations, we're going to do our routine bloods, but the ones to pay particular attention to are our FBC, and that's because anemia is going to decrease the oxygen carrying capacity of the blood, and so our body's ability to mitigate increasing oxygen demand is limited, so we might get the pain earlier in exertion in stable angina, for example. Euthanasia, because a lot of the medication we're going to be prescribing these patients rely on an adequate renal function, and lipids, because we already know that hyperlipidemia is a risk factor for coronary heart disease. And then our cardiac enzyme, so typically this is troponin, so we check this on presentation, but it's important that if that's normal, that we repeat it again in about 6 to 8 hours, depending on the trust, and that's because troponin is a measure of myocardial breakdown. And so, immediately after the ACS, you might not get such a drastic raise in troponin. And imaging. So a chest x-ray might be warranted, especially if they've got respiratory signs, but an echo is important because we need to assess the damage to the heart and whether the myocardium is functioning properly. So in unstable angina, the ECG may be completely normal. Sometimes we can see some ST segment depression, and that does suggest a high risk ACS. Cardiac enzymes are usually normal, and if there is a minor troponin release, that would again tell us that this is a high risk. So as you can see, it's therefore essential we take a really thorough history, because on examination and investigation, an unstable angina may be undetectable. An NSTEMI, so they're going to have symptoms suggesting ACS. Typically they have non-specific ECG abnormalities, so there might be some ST depression, some T-wave inversion. They usually do have some elevated cardiac enzymes, so that's how we can distinguish it between NSTEMI and unstable angina because of this troponin release. So this is an example of an ECG of a patient with an NSTEMI. So we can see some T-wave inversion, not much else really, mainly the T-wave inversion. On this example, we can see some ST depression in the lateral leads. We'll go more into some of these abnormalities in your ECG interpretation talk. And finally, STEMI. So again, symptoms suggesting ACS. We're going to see some acute ST elevation, possibly some Q waves, and almost always some troponin release. So in this ECG, you can see lots of ST elevation, again in the anterior lateral leads, some reciprocal ST depression. Again, we'll go through this in the next lecture. This is another example of an ST elevation MI. So immediate treatment. So as with every acute patient scenario, we're going to do an A to E approach and treat as we find. It's also really important to initiate MONA, and this stands for morphine. So typically we give up to 10 milligrams IV with an antiemetic such as metoclopramide. We're going to give oxygen if needed. The N stands for nitrates, so GTN, which usually is the spray. If they've got stable angina, we can use the spray. If not, we can give GTN IV. And finally, aspirin, 300 milligrams orally. For a STEMI or an MI with any new left bundle branch block, it's essential to speak to cardiology or the medical registrar on call to consider PCI or thrombolysis. Longer term management, the patient will be on dual antiplatelets. Typically this is aspirin and clopidogrel, but depending on the trust, it may be a slightly different combination. Beta blockers such as atenolol, and if they're contraindicated, a calcium channel blocker. ACE inhibitors such as lisinopril and a statin. So some of the complications from ACS often depends on which area of the myocardium is affected and also how much ischemia there has been and how quickly it was treated. But some of the main risks are reinfarction, angina, heart failure, cardiogenic shock or valve abnormalities, ongoing arrhythmias, peripheral emboli, pericarditis, and importantly the psychosocial effects. So there's a greater risk of depression, reduced mobility, and also sort of general social impacts. So in summary, ACS describes a spectrum of coronary heart disease, including unstable angina, NSTEMI and STEMI. It's often very difficult to distinguish between them, especially in the early stages when an ECG and blood test might be completely normal. The risk factors and immediate management are the same for all three, and you'll often hear the words ACS protocol. Important differential is stable angina, and we can separate this from ACS because in stable angina the symptoms are relieved by rest. And there are my references. So thank you very much for listening, and we'll see you again soon.